Great. Uh, Good evening, everyone. Good morning, good afternoon, and assalamu alaikum. We welcome you to our patient-centric care session today, and very excited to have everyone join us. Dr. Nitin and I will be your chair and co-chair for this session. On behalf of both of us, and I'll actually take the liberty to say this on behalf of our speakers as well today, that we are extremely excited to have the neuro-oncology medical community focus on dedicating time to a session on patient-centric care. The aim today in today's session is to basically provide, to sensitize clinicians and to also, sorry, I'm just going to share my screen. Can you all see my screen now?
Yes.
Perfect. So the aim in today's session is really to highlight the exceptional work and success stories celebrated by brain tumor patient organizations across the world, to sensitize clinicians and give an understanding to the neuro-oncology medical community, the areas where patient organizations could use your support, and to remind you to always keep the patient's perspective front and center. We have a joint mission to bring the best care to brain tumor patients and caregivers, and for this, we need to support each other. I'll actually start by asking you a question. Did you know that support groups coupled with medical treatment have been shown to be more effective than standard care alone in most settings? In fact, research shows that patients may find it possible to develop a more active, participatory, and proactive attitude towards the illness, and at the same time may feel supported during the process of recovery. Several research results have also demonstrated the efficacy of psychoeducational support intervention through an increase in functional coping strategies, an amelioration of the quality of life, and a reduction in pain and psychopathological symptoms, mainly depressive and anxiety-related symptoms. And also an enforcement of some biological parameters, such as the ones linked to defense mechanisms, and an improvement in the treatment compliance relationship with regard to family, increase in capacity in terms of cohabiting, facing the disease, and self-efficacy. And this is both in oncologic patients and in caregivers. In fact, more studies show that caregivers have actually benefited from caregiver support groups, and specifically with less depression and less sense of burden. And this is done due to a sense of commonality, a validation of the caregiver's experience, and opportunities to give and receive help. However, I'll pivot to my personal experience because all of this did not exist for myself and for my late husband, who was suffering from a GBM. I can speak from my experience as his caregiver, as Taha was first diagnosed in 2012 and then succumbed to a GBM in 2015. He was diagnosed in a span of a week, and he was diagnosed from being a healthy, active, ambitious 36-year-old to all of a sudden learning that he has one of the most aggressive forms of brain cancer there is. And then the flood of questions started coming to both our minds. First, the more practical questions came, which was, when will treatment go on till? How do we manage work? Should we get a second opinion, or maybe a third or a fourth? And then as treatment progressed and prognosis worsened, the more morbid questions came to mind. What does this diagnosis really mean? Will we ever be able to have kids? And then later, when we moved into his end-of-life care, I started asking questions like, what will life be like for a young widow? And I share this personal story more because this part of our journey was very, very isolated for us. And although the medical support was phenomenal with the doctors on the team, the non-medical support and trying to find people who could relate to us pretty much didn't exist. And with this in mind, we actually set up the Brain Tumor Foundation of Pakistan. It was launched exactly a year ago, and I'm actually excited to say it was launched in September 2020 at the first annual Neuro-Oncology Symposium. So exactly a year ago at this session last year, we shared that we'll be launching the Brain Tumor Foundation of Pakistan. Our mission is to reach every individual in Pakistan affected by a brain tumor. We've launched in partnership with the Pakistan Society of Neuro-Oncology. And we've actually started reaching out online and through various platforms to patients to help raise awareness and provide access to information. With Dr. Essen here, we run monthly support groups with patients. They're small right now, but they are growing. And even though we're a nascent organization providing this support in Pakistan, in a short span of a year, we already have more than 1,500 members in our online community, be they survivors, be they caregivers, or patient advocates. We'd like to make sure we continue to grow and, of course, partner with organizations, patient organizations globally to learn from each of them. And you'll see as we showcase that going forward in this session. But we'd also like to partner and associate with the neuro-oncology medical community in Pakistan. And we invite you to help us reach out to more patients. And similarly, I'll also share that Dr. Nitin set up the Brain Tumor Support Group Awareness Foundation in India with a similar mission of reaching out to brain tumor patients and caregivers in India. And I work quite closely with them as well, especially since when we started our support groups, we wanted to understand how to run them, and Dr. Nitin's team has been super supportive in that front. And Dr. Nitin, I don't know if you want to share a few words about your foundation in India.
Yes, so Komal, our experience has been same. It's been now 2 years, and we are also slowly growing. And I think, as you are aware, we are part of the Asia Pacific Brain Tumor Association Alliance, and with Kathy being in IBTA, I think helping each other out is the only way forward, because it's tough to start with, but as you will see, and as has been our experience, it is really very, very helpful. I am a clinician, I'm a neurosurgeon, and I see both sides of it. And I can tell you that it really helps the patient and their caregivers. So it's congratulations to you. Starting is the most difficult thing, but once you have initiated, you have gone through first year, I think it's just matter of time when you will soon spread. So all the best. And it's also very excellent thought process of the PASNO to have such a symposium, because this is how the clinicians are exposed to what actually we as support groups can provide to our patients and to the caregivers.
Great, thank you, Dr. Nitin. I'll move on to share that we have a host of international and national speakers who will be speaking today and showcase the wealth of work that is being done by patient organizations across the world, and also to let you understand how it feels like to be in the shoes of a patient and a caregiver. Our agenda consists of a speaker series, and at the end we will have a panel discussion which is focused on quality of life and working together to improve the lives of everyone impacted by a brain tumor. We will take in questions, so please share your questions during the session with our moderators. We will try to incorporate them into the panel discussion as we go along. If, however, we are not able to reach your questions, we apologize in advance, and we will be able to respond to you over email right after the session. So please do reach out to us if your questions went unanswered. With that being said, I'd like to introduce you to our first speaker, which is Kathy Oliver, Chair and a founding co-director of the International Brain Tumor Alliance. IBTA is a global network established in 2005 as a dynamic worldwide community for brain tumor patient organizations and others involved in neuro-oncology. On behalf of IBTA, Kathy campaigns for equitable access to brain tumor therapies, encourages the establishment of brain tumor patient caregiver support groups in countries where they don't yet exist, and raises awareness of the challenges of this devastating disease. She is involved in cancer patient rights-based advocacy and is co-author of the European Cancer Patients Bill of Rights 2014 and the Brain Tumor Patients Charter of Rights launched in July 2020. Today, Kathy will be discussing the art of brain tumor advocacy. And I'll give it to you, Kathy.
Okay, thank you very much, Komal. I hope you can all hear me. Yes?
Yes.
Yes.
Great.
Yes.
Okay, and I see you've loaded my slides, so thank you very much. I just want to express my sincere gratitude to PASNO and the Brain Tumor Foundation of Pakistan for inviting me here today. It's a real honor. Thank you very much. Next slide, please. I have no conflicts of interest regarding this presentation. Next slide, please, Komal. So this is my family. On a January night in 2004, my then 24-year-old son, Colin, who is pictured here in the kilt, was diagnosed with a brain tumor. He was an otherwise very healthy young man, as you can see from the photograph. He was a rugby player and a keen bicyclist. He took the news of his brain tumor diagnosis with the optimism that youth often has. But for my husband, pictured here, our daughter, Miranda, pictured here, and me, the diagnosis was absolutely brutal, and it pierced forever, really, our carefree family lives. And I remember really clearly that when Colin went off for a blood test that night before surgery, because he needed an emergency debulking, I turned to the neurosurgeon and I said, "You will get every single bit of that tumor out, won't you? No matter what." And the neurosurgeon turned to me. He peered over the top of his glasses and he said, "Mrs. Oliver, I will of course do my best to get as much of the tumor out of your son's brain as I can. But we need to think of his quality of life after the surgery. I don't want to rob him of his speech or cognitive or physical abilities by being too aggressive and damaging healthy brain tissue. What quality of life would he have then?" Indeed, the plea that I made to the neurosurgeon that night, get all of the tumor out, no matter what, was actually quite stupid, thoughtless, and selfish. But in my fear and desperation as a mother and wanting my son to live as long as possible, I hadn't considered that crucial factor, quality of life. I had only thought of quantity of life. Next slide, please. Now, next slide, please. Now, the author Viktor Frankl wrote, "We cannot, after all, judge a biography by its length, by the number of pages in it. We must judge by the richness of the contents." Next slide, please. We all know that people with brain tumors and their caregivers face significant challenges to achieve that richness of the contents. Next. Even in highly developed nations, patients come up against inequities in accessing therapies, patchy and uneven support services, and not enough clinical trials. Next slide, please. There may also be loss of employment and economic toxicity, a lack of information about the disease, a loss of control of one's life, and a loss of oneself. There is also a lack of rehabilitation, and quality of life does drop. And of course, we all know that there is still stigma attached to a brain tumor diagnosis. Next slide, please. And of course, under all of these daunting circumstances, it's always very hard to sustain hope, but we must all sustain hope at all costs. Next slide, please. Now, our vision at the IBTA is a world free from the fear of brain tumors. And our mission is to advocate for the best treatments, information, support, and quality of life for brain tumor patients, offering them, their families, and their caregivers hope wherever they live in the world. Next slide, please. We try to build bridges between all of the different stakeholders on the brain tumor journey, whether they're patients or families, healthcare professionals, members of industry, academia, policymakers, regulators, and others. And we also work with many different charities, not-for-profits, and foundations, large and small, in the international brain tumor community. In this way, we feel we can have a 360-degree understanding of everyone's perspectives, challenges, and goals. Now, we've been building bridges like this since the IBTA was established 16 years ago. And personally, there are two big lessons I've learned in this time about brain tumor patient advocacy. Next slide, please, Kamal. First, in order to deliver truly patient-centric clinical research and care, we should always go back to patients and caregivers and ask them to tell us what matters most to them. Because understanding the patient perspective is a powerful tool that we can all use to improve outcomes for patients and their families. Next. Second, I've learned that there is huge energy and power when a group of people or organizations with similar concerns come together and work towards the same goals. American Senator Ted Kennedy, who was diagnosed with a glioblastoma in 2008, said, "What divides us pales in comparison to what unites us." And what unites us here today and beyond this virtual conference of PASNO are the huge challenges we see, and many of which we experience on the brain tumor journey. So let me now give you some quick examples of how patient advocacy organizations have worked together to improve the quality of life for brain tumor patients and their families. As I said, we know that in our brain tumor community, there are inequities in accessing optimal treatment and support. And to be honest, this doesn't only happen in developing countries. Even in the most advanced countries on this planet, brain tumor patients can still be lost in a maze of uneven care and support. Next slide, please, Kamal. Now, to try and address some of these inequities and improve quality of life, 10 years ago, the IBTA published a pocket-sized card called the Brain Tumor Patients Charter of Rights, and you can see the original one here. But a few years ago, we felt that this very brief charter needed refreshing and expanding to better reflect changing medical practices and patient perspectives. So in 2016, a new charter drafting group was formed to update the old charter. Next slide, please. At the IBTA World Summit of Brain Tumor Patient Advocates in London in 2017, we had 85 delegates from around the world, and we held a charter workshop for summit participants whose organizations represent literally thousands of brain tumor patients and their families. Next slide, please. From that meeting, we developed the new current version of the Brain Tumor Patients Charter of Rights, which was launched, as Komal said, recently in last year. Now, to date, over 90 patient organizations and professional medical societies worldwide have confirmed their support of the charter, and you can see all of their logos there, including your logos of the Brain Tumor Foundation of Pakistan. We know that many countries lack basic health research and manufacturing facilities, and I'd like to go on to the next slide, please, Kamal. So the new charter addresses a series of rights that are linked to the various stages of the brain tumor journey, from diagnosis to end of life. And the charter also reflects input from a very wide variety of cultures and beliefs. We know, as I said, that not all countries have the capacity to deliver the most modern, scientific, evidence-based care for brain tumor patients. For some countries, therefore, the charter represents an aspirational ideal, which we can all work towards. Quality healthcare relies, of course, on money being available to pay for treatments, equipment, and a well-trained workforce. So we consider that the charter provides a policy tool for patient advocates and healthcare professionals to use when they engage with governments to highlight gaps in care and support and to improve quality standards, healthcare policies, and practices. The charter can also be used by individual patients and caregivers to underpin the things that matter most to us on our brain tumor journeys. Next slide, please. The charter is now available in English and 12 other languages, and thanks to wonderful help from Komal of the Brain Tumor Foundation of Pakistan and her colleague Sufia Zamir, we will very soon be publishing the charter in Urdu as well. Next slide, please. Now, patient advocacy plays a crucial role in another project in which we're involved in Europe, the European Reference Networks, or ERNs for short. These ERNs were created in 2017, and they are collaborative virtual networks of specialists in centers of expertise around Europe who have come together to provide second opinions and expert treatments for people with rare diseases. Brain tumors are a rare cancer, so there is a European reference network for them as well, which is within a larger network for rare adult solid tumors called EURECAN. The role of patient advocates here is key in supporting the European Reference Network's mission to improve standards of care and also clinical research for people who live with a rare complex disease like a brain tumor. Patient advocates work in EURECAN at a very high level indeed. For example, sitting on the EURECAN steering committee, co-authoring clinical practice guidelines, and helping to establish a EURECAN registry for rare cancers. The work of EURECAN can also help improve healthcare policy by identifying gaps in the provision of healthcare services across different countries in Europe. The exchange of knowledge and information within and between EURECAN's 12 groups of all the different rare cancers also serves to highlight potential tools to improve healthcare policies in the future. Personally, I've learned an awful lot working with patient advocates in EURECAN from the fields of sarcoma, myeloma, kidney cancer, head and neck cancer, thyroid cancer, and other rare adult cancers, because we share a number of the same important issues. And as cancer treatments focus more and more on a tumor's biomarkers rather than on the specific part of the body where that cancer started, we're beginning to share some of the same targeted treatments as well. Next slide, please. Now we move on to Sub-Saharan Africa for a third example of the power of collaborative patient advocacy. In 2017 in London, the IBTA gathered together representatives of patient advocacy foundations in Zimbabwe, Uganda, Cameroon, and South Africa, along with the Society for Neuro-Oncology, SNO, that many of you know, and a range of African neurosurgeons and other healthcare professionals. Next, please. Our goals were to start building the foundations for a Sub-Saharan Africa multi-stakeholder neuro-oncology society, to actively involve the Sub-Saharan patient advocacy community in the work of this new society, and to organize a neuro-oncology conference in Sub-Saharan Africa. Next slide, please. It became very apparent very quickly at the 2017 meeting that the African challenges we heard about were really monumental, and the resources to tackle them were few. Patient advocacy organizations at that meeting also shared very moving testimonies, which laid bare the everyday enormous struggles for people in that part of the world in terms of quality of life and access to treatments. Next, please. Now, I'm very proud to say that our initial objectives at that 2017 gathering were met in the space of just a few years. The Society for Neuro-Oncology, Sub-Saharan Africa, otherwise known as SNOSA, was established in 2018, and since then there have been face-to-face international conferences in Abuja, Nigeria, and Cape Town, South Africa. In 2020 and 2021, SNOSA, of course, held virtual conferences because of COVID-19. But the patient voice has been an integral part of these conferences and also SNOSA's work. 2 brain tumor patient advocates sit on the SNOSA board, the executive team, and the testimonies from the patient advocacy organizations at our initial meeting in 2017 helped build the foundation for the SNOSA of today. And I share with you the overwhelming message of the SNOSA project, which has been that working together collaboratively and with one voice, barriers can be broken down, the impossible can become the possible, and dreams can turn into realities for the African brain tumor community. Next slide, please, Kamal. My last example of the power of patient advocacy is from Canada, where Kamal is. In 2011, the Brain Tumor Foundation of Canada conducted a study to determine the feasibility of creating a Canadian brain tumor registry. Because for a long time, the only brain tumor demographic research available to Canadian healthcare professionals came from the US. In May 2019, the Brain Tumor Registry of Canada was officially launched. And an important feature of this registry is that it contains data on both malignant and non-malignant brain tumors. Not all registries contain information on non-malignant tumors. The broad scope and the detailed data in the Canadian Brain Tumor Registry will significantly impact possibilities in securing funding for research and also better treatments, and therefore hopefully lead to better outcomes and better quality of life for people with brain tumors. The Canadian registry was kickstarted by patient advocates, putting up their hands and loudly saying, "I matter, please count my brain tumor." Next slide, Kamal. Finally, I think everyone will agree that at some point in all of our lives, we all may stumble for whatever reason. But for those whose lives have been touched by a brain tumor, it's a devastating tumble, not a stumble, a tumble into what is often a very confusing maze of the new normal, hospital visits, side effects, MRIs, medical language that patients don't understand, and worst of all, in many cases, a very uncertain future. Next slide, please, Kamal. So, in conclusion, we must all work together, building bridges, as I said, collaborations and innovative approaches to living with a brain tumor, so no one ever feels alone or forgotten. We must keep our efforts focused, we must keep our reserve firm, and we must keep our hopes high. Next slide. So thank you all very much for your attention and for inviting me to join you here today. Thanks again.
Thank you very much, Kathy. This was very insightful, and we've been part of quite a few of your activities, and they're extremely, extremely helpful for new organizations like ours. Appreciate it. Okay, keeping time in mind, we will move to our next talk for the day. I'd like to introduce Dr. Suzanne Chang. She is professor in neurological surgery at the University of California, San Francisco. Dr. Chang has a major research focus on the development of novel therapies for patients, as well as the assessment of novel imaging markers of prognosis and response to therapy. Dr. Chang has also created novel clinical programs such as the Gordon Murray Neuro-Oncology Caregiver Program and the Sherry Sobrato-Bryson Brain Tumor Survivorship Program, both developed to enhance the care of patients and families. Today, Dr. Suzanne will talk about survivorship, surviving, thriving, and living well. Just give me 1 second as I share the slides.
I would like to thank the organizers for inviting me to give this talk on surviving, thriving, and living well, supporting our patients through the brain tumor journey. According to the U.S. National Cancer Institute in 2018, an individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. And we know that family members, friends, and caregivers are also impacted and are therefore included in this definition. This commentary in JNCI on developing a quality of cancer survivorship care framework has implications in terms of clinical care, research, and policy. This group identified not only the various factors that can affect the ability of patients to have a good quality of life, but also outlined the specific areas of healthcare delivery that need to be addressed. Now, we know that brain cancer survivors constitute a vulnerable population with distinct and complex medical, psychosocial, emotional, and cognitive needs, and that these needs can change throughout the disease journey and negatively impact the quality of life. And general cancer survivorship resources often fall short in meeting the unique needs of brain cancer survivors. But efforts such as the creation of a neuro-oncology survivorship care plan are now emerging to address this. And these are important communication tools to help foster and share better understanding of follow-up care after active treatment. They also provide recommendations to help anticipate future needs as it pertains to the longitudinal aspects of care. So we wanted to basically form a survivorship program to support our patients. And our efforts started with listening to the patient. We heard patients express issues with adapting to their new normal, coping with lingering side effects and symptoms, role changes, disruption of family systems, fear of cancer's recurrence, social isolation, and a search for renewed meaning, purpose, and hope. Yet many also voiced a deep gratitude and appreciation for their life, as well as a desire to give back while they still could. What we really heard was that although survivors were continuing to live, they really were not thriving. And thus the survivorship program responded to these issues by providing an array of holistic, patient-centered services to help empower survivors to be the healthiest version of themselves. We felt that this was important, sort of as acting as a bridge to make sure that patients moved from surviving to thriving. So the mission of the Sherry Sobrato Brisson Brain Cancer Survivorship Program is to enhance the wellness and quality of life of patients with brain tumors through a collaborative, multidimensional approach focusing on emotional, physical, and cognitive health. We really focused on two questions. What does it mean to live a great life with brain cancer? And how can we support our patients in doing so? We're very fortunate to have an amazing team of core members. So myself, Naomi Hoffer, who's an amazing program manager, and Lex Greenstein, who is a RN and nurse practitioner, to help coordinate all of the resources for our patients. We have amazing collaborators that extend from social work, exercise physiologists, integrative oncology. This is where we're looking at other types of care for patients like nutrition and alternative medicines to integrate with standard of care. And then we have important subspecialty physicians, including those in neuropsychology. So these were the pillars that we felt to provide the patients with the best individualized survivorship care possible. And the pillars will briefly describe over the next few slides. As I said, this survivorship program really includes key pillars of cognitive care, workout for wellness, or WOW, some events and classes, living well resources, and peer support and community. So for the cognitive care clinic, we wanted to have a personalized, holistic, patient-centered cognitive care with comprehensive consultation and management as it relates to quality of life. And some of the things we incorporated included not only cognitive testing, but also education and resource linkage, return to work intervention, caregiver training, goal setting, and legacy projects, which really was allowing the patient to have a voice as to their life and meaning so that their families can have this. We again wanted to make sure that we personalize this to our patients. And this is a metric of how many patients we have actually helped over the last 2 years. So you can see the types of efforts that the team is providing in terms of testing and screening and caregiver training, as well as resource linkage. We also have a component of cognitive research led by Jenny Taylor and Chris Jamora Wire, And this is where we are looking at intervening with assessing the feasibility of cognitive rehabilitation in patients with stable low-grade glioma, where we're collecting preliminary efficacy data on various intervention. There's also a longitudinal arm where we are following newly diagnosed patients prospectively to identify timing of clinically meaningful cognitive change, to try to correlate that with tumor characteristics and imaging parameters. So our workout for wellness is really important. We've seen more and more evidence that exercise not only helps with a sense of well-being, but also allows patients to improve on symptoms like fatigue and sleep. So we offer one-to-one exercise counseling to assess the individual goals and assess resources to create this individualized program. And we also have reduced or complimentary memberships at participating facilities. We are working on a new app that really focuses on patients who have difficulty with balance or weakness and may need to be either in a chair or in bed, so that we can ensure that these patients still have an exercise program tailored to their current level of functioning. For the events and classes, this is something that we felt was important in terms of providing education. So we have a series of Living Well webinars that are held once a month, and they always include a survivor voice, so there's meaning to these various topics. And there is an after the show segment for community building. And all of these are actually recorded in our video library. And these include numerous topics such as relationship resilience, strategies for coping with cognitive changes, thriving as a young adult, neuroplasticity in the human brain. These videos are free and available on our website, and we add them every month to the program. We also started an Integrative Approaches class series with Donald Abrams, who's an internationally known integrative oncologist. And this sessions include group instruction as well as individual consultation on cancer nutrition, plant therapies, and non-traditional medicine for cognition and fatigue. We usually have about 7 to 10 patients for every class, and we also encourage care partners to attend. This is something that we have found to be very, very well received by our patients and the families. So talking about our handouts and resources, we have developed as a single issue informational sheets on various topics related to cognitive strategies, emotional health, diet and exercise, traveling, mindfulness, and we continue to develop these as needed, with translating them also into other languages such as Spanish, and also will be accessible online and as a manual. One of the things we've heard from our patients is the sense of isolation, and that unless someone has been a brain tumor survivor, they really don't understand what they're going through. And so we felt that this sense of isolation needed to be addressed. We have this ability to have peer support and community building and connection with these support programs. So we have a peer support volunteers that are trained to provide comfort and practical information. And we have a weekly Thrivers group so that these peer support volunteers can get the advantage of coaching tools and one-to-one connections. We also have a brain tumor support group and also communicate with a Thriver newsletter. So in summary, this is very important in terms of having a patient-centered approach, which is one of the things I love about this particular session, is that we're really keeping the patient at the center of everything that we do. So if we think about developing a survivorship program, we need to make sure we recognize the patient needs across the trajectory of the illness, to garner support, to build a program and team, to provide opportunities for support and resources exploring electronic-based practices. And this is something we've learned in the COVID pandemic, is that we can transition a lot of this into these virtual meetings, which really alleviates the difficulty with access to a lot of our resources. So we've had amazing attendance at our meetings. We were holding these in person at first, and we would, have maybe 10 or 12 people attend. However, now with the webinars that we've developed, we can have up to 60 people attend. So that's amazing. We also need to address sustainability in any program that we develop. So wanted to talk about how we approach things at UCSF in terms of really integrating clinical care, basic science, clinical trials. These are all the things that are really going to push the field forward in terms of new discoveries for effective therapies. However, we need to keep this in mind in terms of supportive care services that span both the patient and the caregiver. And so I think that the ability for us to provide cutting edge care and quality care is really key to moving forward with how we take care of our patients. So we have an integrated and comprehensive supportive care program at UCSF. As I mentioned, this really centers on the patient and the clinical care of the patient. So we really integrate these programs, the survivorship program, social work, palliative care, and our caregiver program, all to improving the quality of survivorship for our patients. So I'd like to thank you for your attention, and also to thank the generous supporters of the Gordon Murray Caregiver Program and the Sherry Sobrato Brisson Survivorship Program. Thank you.
Great. Thank you so much, Dr. Suzanne. This was extremely insightful, and especially for new brain tumor foundations like our own, I feel that this is almost like a North Star for us to be able to have a separate patient survivorship program and a separate caregiver program. Of course, right now we just do it all in one, but that really for me would be the North Star. Thank you so much. Moving on, I'd like to introduce our next speaker, which is Christy Naines, Executive Director of Brain Tumor Network. Christy has worked in the nonprofit and healthcare sectors with a desire to serve the community. Her experience with a rare cancer diagnosis has turned into a passion for helping others with the disease. She spent many years at Mayo Clinic, connecting with patients on a personal level and helping to inspire others to advance research and excellence in patient care. As Executive Director of Brain Tumor Network since April 2019, Christy's vision is to provide the best navigation experience with compassion while strategically evolving to reach more patients and more caregivers. Christy's topic today will be on brain tumor patient navigation. I'll hand it to you, Christy.
Thank you so much. Good morning here in Florida, and thank you for allowing me to be here today. It's a pleasure. Next slide, please. What is patient navigation? This is a fairly new profession, probably in the last 10 to 15 years, and we view it as individualized assistance offered to patients, families, and caregivers to help overcome healthcare system barriers and facilitate access to quality healthcare from pre-diagnosis through all phases of the cancer experience. So really, we view it as trying to help families understand their diagnosis and find the best care for them at the right time. Next slide, please. You will hear actually from Dr. Suzanne Chang, who you just heard from. She did a video for us to explain what is personalized navigation. So if you wouldn't mind, go ahead and playing the video.
Hello, my name is Dr. Suzanne Chang, and I am the Director of the Division of Neuro-Oncology at University of California, San Francisco. The diagnosis of a malignant brain tumor is frightening and challenging, not only because patients face a serious illness that has a poor prognosis, but also one that can have significant effects on their physical, emotional, and cognitive health. Navigating the course of their journey can be overwhelming, not only in terms of understanding the disease and treatment options, but also having to deal with the complexity of the healthcare system. The multidisciplinary approach to the care of the brain tumor patient is critical to address management options across the disease trajectory to ensure that outcomes are optimized. And one of the critical members of the team is the patient and caregiver navigator, whose role is to assess the individual needs of the patient and the caregivers and link them to important support resources. They also provide education to improve knowledge and practices regarding the disease and enhance communication across the members of the team.
Thank you. Next slide, please.
If you live in a qualified zip code, you may be eligible to receive USA-made solar panels for no cost at install and get paid more than $2,039 after the panels are installed on your home. Here's how it works.
Sorry about that.
That's okay. That's all right. Thank you.
That's okay. We can charge them for a few seconds of advertisement.
Yes, absolutely.
So our mission at the Brain Tumor Network is to provide compassionate and personalized high-touch navigation to patients and their caregivers in the United States who have been impacted by a primary brain tumor. And we have another video, hope it doesn't complicate things, that really explains what we do.
Great. I will go back here and
Thank
play
you.
it. No problem.
If you or a loved one has been diagnosed with a primary brain tumor, chances are you have more questions than answers. The amount of information you receive can be overwhelming, and you may need support in navigating your diagnosis, treatment options, and available resources. The Brain Tumor Network was conceived by a family who knows firsthand the difficulties faced when told you have a brain tumor. Brain Tumor Network is dedicated to guiding you and your loved ones through the often complicated brain tumor treatment journey. This personalized navigation service is offered at no cost to patients and caregivers. Personalized navigation is guidance provided by experts to help you understand your diagnosis and get you connected to the care and resources you need quickly and efficiently. Our navigators build meaningful connections with you to understand your priorities and guide you to treatment options based on your unique situation. Your dedicated navigation team will remain with you for the duration of your care at Brain Tumor Network, helping provide guidance and information for services including understanding treatment options, clinical trials, second opinions, education, emotional support. The Brain Tumor Network believes no one should travel this path alone. We are with you at every step, ensuring you have access to the best possible care, support, and answers to your questions along the way. Request a consultation today at www.braintumornetwork.org or by calling 844-286-6110. We stand ready to assist you.
Thank you. Next slide, please. So one thing that makes us unique, through the United States, there are navigators within certain medical facilities. We are not associated with any medical institution. So we really try to take an unbiased approach and really don't steer any patient to any certain institution or a provider. What we do is we connect patients to disease experts and facilitate consultations. We assist with locating treatment centers with a focus on centers of excellence. We provide education on current approved treatments for brain tumors and the side effects. And we locate second and third opinions while considering geography and ability to travel. We really look at the number of patients that the providers have seen and their experience with it to really direct people who might live in rural parts of the United States to more experienced providers with a focus on neuro-oncology. Next slide, please. So one of our signature services, about 30% of our patients really need help finding clinical trials. We have built a own proprietary clinical trial matching system, which takes into account the location of the tumor, if it's a second or third occurrence, and the biomarkers and molecular profiling to find clinical trials that the patient might be eligible for. We then will reach out to the institutions to find make sure they're still accruing patients before we offer them as suggestions to patients and caregivers. We also collect medical records and on behalf of the patient and deliver them to different providers on behalf of the patient when they're looking for second or third opinions or clinical trials. I try to say we really try to take some of the administrative burden off of the patient so they can just focus on getting the care that they need. Our navigators also assist with answering questions and topics to discuss with care providers. A lot of times patients and caregivers don't even know what questions to ask. So we're happy to provide some of those questions for them. We're also happy to virtually go to the patient appointment with the patient. So whether that's on a Zoom call or a phone call, we are able to do that and just really listen and help interpret later on any questions or answer any questions that the patient caregiver may have. We have social workers on staff that help with referrals, psychosocial support care along the care journey. Really, these social workers help with palliative care discussions, long-term planning, and help locate financial resources. We do not provide medical advice, opinions, or recommendations. We really present different options for patients and caregivers to discuss with their care team. And all services are provided at no cost at all to patients and their caregivers. We rely truly on philanthropic support. Next slide, please. We have a team approach. When someone contacts us, they are immediately assigned a neuro-oncology nurse and an oncology social worker who will be there with them along the journey. So anytime that they reach out to us, they will receive answers from the same social worker and the same nurse. And that relays their brain tumor network care team. We call that our co-navigation model. We also have a retired neurosurgeon on staff, so we can consult with him at any time if we have any questions. And then as a team, we really address each patient, make sure they're well supported. We do a psychosocial intake and a medical intake to make sure we're addressing their needs, concerns, and goals that they may have. Next slide, please. And you might want to hear from Jeremy and Kelly on their experience with the Brain Tumor Network from their perspective.
I had gotten a call from Dr. Willis. He said, "Hey, I hate to do this over the phone, but it looks like you have a glioma about the size of a golf ball, and I need to get you in an MRI machine as soon as possible." I basically just kind of started crying on the spot.
At that point, the doctors were very much telling us, we don't know what it is. We just know it needs to come out. It was 7 days from his first symptom until surgery. So it was just a whirlwind. I mean, just like everybody says an experience like that is going to be. For me, one of the things that I feel like has come out of this is remembering the importance of not always looking for something to look forward to, but to look forward to what's happening right now. today is what today is, and to be grateful for that. I think we really try to do something every day that we can look forward to. Let's find a new TV show to watch as a family. Let's go on a family bike ride together. Let's go on a hike together. Let's kayak together. Yeah. It is pretty cliche when you hear people say, you just have to appreciate every day for what it is. You have to live in the moment.
But you do.
But it's cliche because it's true, and you do have to do those things.
You know, I think every hospital, in theory, wants to treat the whole patient, but it doesn't always work out that way. And I think that the Brain Tumor Network,
they really have kind of provided a wide spectrum of services, and they provide the emotional support, but also the resources and the information, and help you figure out what questions to ask. And I think they're providing the information that we need and the research that we need, but also encasing that in the emotional support too, which is the way we need it delivered. Yeah. You know, I think right now what specifically has been the most helpful for us is they are really helping us to research clinical trial options, because they can put in the legwork. They can really do the research to find what's out there that we don't even know about, and that we don't always have the time and mental energy to look into.
It's a lot for everybody to go through this, right? And it also is nice to have somebody to tell all of this stuff to.
Yeah.
Without adding more stress.
I think when you find yourself in a position like this, that you have to go seek out that help and not wait for it to come to you. The Brain Tumor Network they've done a lot, and I know that they're going to continue to be there for us.
Thank you. Next slide. So you heard Jeremy and Kelly talk about our clinical trial navigation. Like I said before, that's a signature service for us. And we really focus on this because we hear a lot from patients that they are fearful of enrolling clinical trials. They don't know how to go about it. They find it difficult to access information about clinical trials. They're unsure how to search for and understand the eligibility requirements. They're also fearful of discussing this as an option with their current care team, especially if their provider has not brought up clinical trials to them. And then a lot of them face barriers with location or financial challenges. So we really go through each one of these barriers and see how we can help break down that barrier with them. Next slide, please. Patient record, we would collect patient records from every provider that they've seen, and we use them to make sure we are finding personalized and unbiased clinical trials that we may be eligible for. We have developed relationships with brain tumor centers nationwide. Actually, we have relationships with over 500 providers. And so we can really reach out to some of the PIs or clinical trial coordinators and discuss each case with them to make sure it would be a good fit. We also have our own proprietary software system that helps us vet the clinical trials and make sure it may be a good fit for the patients. Next slide, please. About 30% of our patients contact us wanting help securing second and third opinions, just to either verify the information they're getting from their current care team or to seek out different types of treatment. So we are happy to do that because we have been doing this for many years now. We're able to find different providers for them. We help reach out, make the appointments for them. We can facilitate virtual second opinions or just have different care teams review the medical records for us. We will do this for all phases of the brain tumor journey with neuro-oncologists, radiation oncologists, neurosurgeons, neuropsychologists, or neuropathologists. Next slide, please. Most of our patients are requesting some sort of patient education, so we are happy to provide that as well. And we do this throughout the whole brain tumor experience. This includes helping them understand their diagnosis, different treatments and side effects associated with those treatments, and as I mentioned, clinical trial opportunities. Next slide, please. As I mentioned, we have oncology social workers on staff, and they provide the emotional and psychosocial support. A lot of this has to do with adjusting to having a new diagnosis and coping. We help navigate family communication and difficult care discussions. Oftentimes we will do Zoom calls with the whole family to really help navigate the emotional impact. Fear of cancer reoccurrence, we walk through patients through that. Survivorship concerns, and locating resources to assist with financial assistance or practical needs such as speech pathologists, wheelchairs, or walkers. Next slide, please. We are happy to say that 100% of the individuals who are engaged with the Brain Tumor Network in 2020 were satisfied with the services that they received, and 100% would recommend us to others. 94% felt that the navigation they received helped them better cope with their diagnosis. And 87% indicated that the navigation they received helped them feel more empowered to engage in open conversations with their care teams. Next slide, please. And that is my presentation. Thank you again for giving me the opportunity to be here. I am happy to answer any questions over phone or email, and our contact information is on this slide. Thank you.
Great. Thank you so much, Christy. This was extremely, extremely insightful. I think you mentioned that this started about in the last 10 years, this concept of patient navigation, and I can just imagine how helpful it would have been for in my experience, if we had one single point of contact throughout our journey. So thank you for sharing this. I will definitely connect with you to learn more. Moving on to our next speaker for today, we have Anita Granero, founder and president of the charities Oscars Angels and Oscars Angels Italia. And Anita has basically founded this foundation, this Oscars Angel, to support teenagers and children who are impacted by brain tumors. They do this through a network of volunteers that they train, and basically they work to support these families and patients in the heart of the hospital, and have this very specialized volunteer program to do this. I'd like to share that Anita will be talking specifically about specialized volunteers in the heart of the hospital from a pediatric neuro-oncology point of view and from a pediatric care point of view. I'll give it to you, Anita, to start.
Much, and thank you first of all for inviting us here. And what you're gonna hear about is something that we invented, if you want, this new member of the multidisciplinary teams. But it's something that can be done anywhere. In our histories in pediatrics, but you will see that you can adapt that anywhere you are. So please, the next slide. Okay, these are just our t-shirts. As you say, this is the Italian t-shirts. A volontario is one of the members of the team, is the volunteer. Next slide, please. So that's a new member of the multidisciplinary team. Yeah, that it was prepared by one of the children. So you can see the slides are very interactive. Next slide, please. The timeline is these. Just keep going, Kumal. That's it. We were created in 1998 in France at the Hôpital de Toulouse, l'Hôpital des Enfants de Toulouse. And we have been working forever with Italy, of course, to support also Italian families, not with the volunteers in the hospitals, because I physically was in France, but with all the networking, advocacy. And it was in 2018 that the hospital in Rome, the Bambino Gesù Hospital, asked us to, I met them during a congress, and they asked us to think about training volunteers for them as well, because they really wanted to have that kind of help. And so that's what we did. We created Oscars Angels Italia in 2018, and we started immediately at the hospital Bambino Gesù. And now we also have another program of volunteers going into the pediatric hospital in Turin, which is another very big hospital in Italy. And that is, I have to thank Professor Franca Fagioli, which is the director of the children department, for her insight and for really believing in our program. So we will start that. Probably we already are there with the financial help or the support that we give the families. We are not there with the volunteers yet, because they are not still open for new volunteers because, of course, the COVID problems. But we carried on working anyway in France and in Rome, because we already had volunteers there. Next slide, please. These are our pediatric expertise. That's what we are trained for. That's what we are following. The CNS tumors, of course, with a particular focus on very rare brain tumors, the IPG and the ATIT. Of course, bear in mind that here we are talking about pediatrics, okay? We follow also all the neurosurgery, the severe head traumas, the pediatric palliative care, the quality of life, and also in the ICUs where we are present, we take care of the cases of anoxia and severe burns. So as you can see, these are very heavy situations that we have to deal with in supporting the families. Next slide, please. These specialized volunteers, like we like to call it, so the actually hospital likes to call it, is really a link between the health team and the family. That's what we are. And we give human, spiritual, and financial support, which is very important as well. And you will see afterwards in what manner. Next slide, please. We are, as I said, in France, first of all, at the Hôpital des Enfants de Toulouse, in Rome, in Turin, and in Monza. These are the first 4 places. In Monza, we just give an external support. We don't have volunteers inside. We have them in Turin. We will have them, and in Rome. Next slide, please. Who is the specialized volunteers? We said is a new member of the multidisciplinary team. And what it is more important to understand that it is a constant throughout the patient journey. That is what they needed. And we specialize especially specialize in neuro-oncology because of the pathway of the patients, because the patient doesn't just stay in one of the wards. The patients go through surgery and then the ward of neurosurgery, but then he goes down to the operation theater, then he goes to the ICU, then he goes to oncology for treatment, and then he goes to the radiology. So he just navigates. And what we do is that we navigate with them, and it keeps that constant presence of somebody they actually need, know, and trust. And we have a system now in France that starts from scratch, from the emergency department. As soon as they arrive, we are present there. Next slide, please. So here are just some pictures going on. Just keep going. And you will see some pictures of the volunteers that we have, and the fact that we actually allow the parents to go down with the children to the operation theater, and that is because the charity coordinates everything, and the teams, the operation theater teams are comfortable enough to allow one of the parents inside for anesthesia. Keep going. Next slide, please. These are some of our really striking innovations. So the volunteers are members of the hospital teams, 100%. They are considered members of the team. The team shares information with us, like that they don't share with other volunteers, classic, I would say, volunteers, which are extremely important, of course, but I have a different focus. Our focus is not really the children. Our focus are the families, and we are the link between the teams and the families. Another thing that we put on the hospital in Toulouse is the on-call volunteer. So we have now a volunteer or a couple of volunteers that are on call nights and weekends, and they can be called by the ICU or by the neurosurgery operation theater if there is one child that arrives for an emergency surgery, so that the family is not alone, which was the case and is still the case in many hospitals, the lack of support at the moments where they needed it the most. So we filled that in. And another specialized volunteer is another specialized team of our volunteers are on call and available 24/7 for the palliative care and end-of-life care of the children in hospital. Next slide, please. This is what we were saying before, the pediatric patient path care way. For what concerns our charity, we are really based in neuroscience. Everything that touches neuroscience, so neuro-oncology, neurology, neurosurgery, and the ICU, going till the end, till the palliative care, and till the end of life, because that is part of the life of some of our children. So we had to specialize in that to be able to be with them right till the end, if that was the case. Next slide. This is just who we are. It's just, as you can see, 100% member of the team, where you have all the other characters of the movie, and we just one of them in addition, one more. Next slide, please. The other value, actually, I asked the medical team to do it, both the one in Rome and the one in Toulouse, and that's what it came out with. And I think it's just spot on. It's the daily constant presence that we are, the role of mediator, which is a mediator that is there daily. So things don't get too stressed. When there is a problem, we are there too. We talk to the family in a different way, with different words, and things just, the pressure goes down very easily. We have an active listening, of course, a present in emergency, a different perspective that we can bring, not to the family there, but to the team. And that was the most important thing they said. They have another view of what's going on in the family. Better information, because we just vulgarize on and on and on, or whatever information is given. And of course, we have the time to do that, which is very important. And that, creates an improvement of the patients' and families' quality of life. But I would say also the quality of the work of the teams in the hospital. Next slide, please. How can we do that? First of all, you have to have the will, the collaboration of the healthcare professional, of course, otherwise you go nowhere. You have to have the trust. You have to have an absolutely rigorous selection and training of your volunteers, and you have to have the family support that allows you to just get into their lives at that moment, the very difficult times, and allow you to help them. Next slide, please. that is something that is done, as we said, with a very rigorous training. That is our training. That you have, you can see, you have different level of selection, going from the first phone call, the interview with me as a president. Then they begin training, and the training goes from 6 months to 1 year in the hospital as tutoring training. Then they have the psychology evaluation, and the final evaluation, you can see, is done not just by the charity, even if it's the charity that takes the decision, but is done with the senior volunteers, with the psychologists, of course, but with the medical teams as well, because this person is going to be a member of that team, and they have to feel absolutely comfortable with it. The selected volunteers then do start to what we call them being senior volunteers or tutors, and they can themselves train other new volunteers. And next slide, please. This is the practical, if you want, training, but we have a theoretical training as well. These are what we call the modules. They have 10 modules they have to follow during their training, and you can see they are very specific, they are very pathology oriented, because they have to have knowledge of what they are going to face, or they have to have knowledge of what the families have to face to be able to help them and to be able to understand what the families say. They have to have these informations, and these modules are done by the same doctors of the hospitals that participate, as you can see, really deeply into the training of our volunteers. Next slide, please. We might not forget the advocacy, of course, because our charity is also a charity of advocacy, of trying to bring the voice of the families and the patients as well outside the hospital, and trying to get the best possible treatment for them. Now, we do advocacy on a higher level, on a national level, on an international level. What we managed to do with Oscars Angels France and Oscars Angels Italia is to put an advocate right in the hospital, right at the lowest level of the advocacy, which means the wards, right next to the patients and the families, not just the commissions and then the direction of the hospital, but right there, bringing the voice of the families on a daily basis. Next slide, please. Now, this is the advocacy in the health sector. Kathy Oliver of the IBTA spoke very well about it, so you don't need me to go on with that. So next slide. And we do our part of the IBTA, which it brought us a extremely great knowledge of what was going on the international level for what advocacy is concerned, because I think that the kind of charities we are need to have a grasp on what's going on an international level, not even just on a national level, but international, to be able to help our countries as well to improve their representation of patients and families. So we are members of all these Italian and French advocacy groups, which is wonderful. Then the next slide is the one that just shows through the IBTA, the members. We are members also of these groups. Next slide, please. And why is it great? Just click once more, because it's zero cost. That is the key. You know, we do not cost anything to the families, of course, and to the hospital as well. And that is the most important thing. That it means is society that brings the efforts together and say, okay, we are close to this charity and we help this family inside in training, with the training cost and with the financial help that we give for emergency to the families. Next slide. So I'm just thanking you all very much. I hope I didn't take too much of your time, and I try to talk as fast as I can. But being Italian, it's easy. Thank you very much.
Thank you so much, Anita. This is actually incredible. Just listening to you, that these highly trained volunteers are in fact part of the healthcare team, and they're considered to be part of the hospital care that the patient receives. And in my mind, I'm thinking that they represent the family. They're probably able to bring a very different perspective, and bring that perspective of to the healthcare staff of the emotional stress and needs of the family, which are probably not on the medical side. So I think this is actually quite phenomenal, the work you're doing. Thank you for sharing it with us today. Great. We'll move on to our next speaker for today, which is Melissa Lim, founder and president of Brain Tumor Society Singapore, BTSS. Melissa is actually a former brain tumor patient herself and a caregiver to her late mother who had a GBM. Melissa established BTSS in 2014 to connect brain tumor patients, survivors, and caregivers in Singapore, and build a supportive and caring community. BTSS is the only non-profit organization serving the brain tumor community in Singapore. And her topic today will be roles of medical professionals in patient organizations. Go ahead, Melissa.
Hello, everyone. Thank you for having me in tonight's symposium. And yes, today I'm going to talk about the role of medical professionals in patient organizations, because medical professionals actually play a very big role in the establishment and the success of BTSS. So I was a patient who took a tumble when I stumbled upon brain tumor, in the words of Kathy Oliver, and it was extremely difficult to navigate not just my confused feelings about the diagnosis, but also the information and the decisions that I had to make. So BTSS was founded in 2014 to help patients in Singapore navigate this confusing period that they find themselves in, and also the information and the care that they need to find in answers to the questions about seeking a cure. So BTSS was founded in 2014, and our mission really is about surviving, and in the words of Dr. Suzanne Chang, moving from survivorship to thrivers. So we help patients and caregivers from all walks of life, because we know that brain tumors do not discriminate. Initially, when we started off with BTSS, we will only focus on the adult segments, but later on we found in our midst many families who had children who needed advice and support. So currently we serve about 250 families in Singapore, and about 20% of are actively supported. Now I'd like to share my story about how the medical professionals got involved. Very soon after BTSS was established, I suppose the time was ripe in the sense that there was growing awareness amongst the medical professions who treat brain tumor patients as well, that there seems to be a lack of peer support for these patients. And they recognize the need to have a patient organization to help them bridge the needs of, to meet the needs of patients. And at the same time, one of them, who is now BTSS Vice President, Dr. David Loh, he just came back to Singapore from his specialty training overseas, and he saw the wonders of peer support groups where he was practicing then. And he decided that the same thing needed to happen in Singapore. So he heard about BTSS, and he came to me to offer his help in supporting BTSS. At that moment, we were we were just founded and we had really nothing. And at the same time, there were other medical advisors from other health institutions who heard about us, and they also reached out to me. And together, we were able to form a medical advisory board. And this medical advisory board is multidisciplinary. It comprised of radiologists and oncologists, as well as neurosurgeons from public hospitals, which provide the care for the majority of patients in BTSS. So I've given you some links here, so that's easy for you to check out who is on our medical advisory board. So what do our medical advisors do? Well, first of all, they refer patients to BTSS. This is very important, and somehow as medical advisors, they would understand the needs that these patients have, whether it's emotionally, psychologically. They are in a good place to actually inform the patients of BTSS, because BTSS offers befriending support. Befriending support, we mean one-on-one peer support. We have enough patients right now to be able to match a survivor with someone with the same condition that has been recently diagnosed. At the same time, BTSS has peer support groups. Once upon a time, we used to operate out of a healthcare institution. However, due to the pandemic, we started Zoom support groups, and we have them once every month. So we find that our Zoom support group has been expanding, and it's a place where the newly diagnosed found it extremely useful to meet other patients who have actually survived and thrived despite the conditions. We have recently started a Zoom support group for parent caregivers as well. And at this stage, BTSS has been able to form subgroups to support each other. For example, we have a subgroup for GBM caregivers, which all of us would know have very different needs from other subgroups. We have a subgroup for pituitary tumor patients, as well as a subgroup for meningioma patients. So medical advisors are also aware that sometimes their patients need practical and financial assistance, and this is the platform where the patients can gain help from BTSS. Of course, because we are dealing with brain tumors and they are very complex conditions, one of the things that BTSS seek to do is to empower our patients to make informed decisions. And we know patients have a fondness to check with Dr. Google and Professor Google, and sometimes they scare themselves in the process. We want to make sure that our patients receive credible information that they should consider. So our BTSS medical advisors actually help us to put together resources that would be useful to these patients and caregivers. And all the resources that we feature on BTSS website have been compiled and vetted by our medical advisors. So it becomes quite easy for me to say that, okay, you want to know about this? Can you go to our website resource and read about it there? Then the other thing that we do quite often is to organize medical talks. And of course, our medical professionals on board would be the people that we look for these medical talks. We have them once a quarter, and our medical advisors have been very generous in offering their time and expertise to help address the questions that our patients may have during these talks. Once in a while, BTSS will also we refer back to our medical advisors when we receive questions. The questions come in through our Facebook and perhaps even on the WhatsApp groups that we have about novel treatments that they hear about or they read about in neuroscience magazines, or perhaps they saw something in in the webinar and things like that. So of course it's really difficult for us in BTSS because we are not qualified medical professionals to answer these kinds of questions about novel treatments, and our doctors support us in responding to these kinds of questions. So what I have on this slide is also a poster to show you an example of the medical talk that we've had. So instead of having the perspective of course, the usual neurosurgeon or chemotherapy, right? We have had also the other healthcare professionals speaking about like speech therapies and also physiotherapy coming on board to share about recovery from certain conditions. Okay, now I often rely on our doctors and our healthcare professionals to inform their peers about BTSS. And this really helps to create and promote visibility for BTSS. So what our doctors have been able to do is to sponsor lunch, refreshments, and tea, and invite all the peers to come along to hear an introduction of BTSS by myself, as you can see in this picture right here. And it's extremely useful because when their peers, for example, the medical social workers, hear about BTSS, they would definitely refer the brain tumor patient to us. So it really minimizes the kind of publicity that we need to do on our own as a patient organization. Then at the same time, our medical professionals get involved with us in our events. And this is where they mingle with the patients, the caregivers, and the families in informal settings such as Christmas parties, for example, or perhaps celebrating Chinese New Year or National Day, for example. And it creates a community that is really very cohesive. It's not just about patients and caregivers and our families, but it's also about medical professionals being involved with us as a community. Last night, for example, one of our beneficiaries just turned 21. And his mom reminded me to say happy birthday to him. And she told me that she would really like, his doctor, who is one of our medical advisors, to also say happy birthday. And we very quickly connected in a telephone call and we surprised him, just like that, to say, hey, happy birthday, how are you? And to celebrate his life. So other things that our doctors do is to provide support for our awareness events. For example, BTSS has a signature event that's called the Brainy Car Rally, and that's what you see in the background. So, of course, this is a very happy and important event for our brain tumor community, and it's usually held in conjunction with the IBTA Brain Tumor Awareness Week around the world. So the doctors will come on board by offering the institutional support. For example, the National Neuroscience Institute, the Singapore Healthcare Group, and they all come on board, to give that institutional credibility and support for our events. And during these events as well, we often feature exhibitions. And of course, we have our beneficiary stories, which are very, very important. But at the same time, for example, in our 2018 Brainy Car Rally, our doctors actually feature the Medtronics equipment, which they use to navigate neurosurgery. So it became part of this exhibition as well. And often the senior doctors would encourage their junior doctors to form the first aid teams for us during such events. And of course, they helped to inform the patients and the peers about our awareness events. And that helped make this event more vibrant and exciting. So another project that we involved our doctors was in advocating for the Singapore Brain Tumor Registry. It's not, I would say that one that's still in the works. It's not very easy to really advocate for this cause. What happened is that in Singapore, the latest statistics that we have about brain cancer, it's in 2007, that's so long ago. And of course, we wanted more updated statistics. And the statistics that's released tends to be focused on the major kinds of cancers that Singaporeans and residents suffer from. However, to overcome this problem, of course, we met with the Ministry of Health together to explain why this is important. But until we reach a collaboration or an understanding with the Ministry of Health, we help ourselves in the sense that sometimes when we need to understand numbers, we share between ourselves, of course, protecting patient confidentiality about the kinds of numbers that we are looking at. And we found, for example, that a great number of patients actually suffer from secondary tumors and not the primary ones. The other thing that we're working very closely would be in the area of advising and gaining access to new treatments. This has been the thing that's been keeping the medical advisors quite busy with Btss. For example, in February 2020, just when the borders were closing because of the COVID-19 situation, right? So Btss and the hospital and the doctors, of course, as well as the patients, and we work with an external third party to develop a new access inroads to an Optune TTF device to be brought into Singapore. And because Btss was involved, we are also able to share with the rest of the doctors who are in the advisory panel about what happened in this very first experience and what should we be doing forward, perhaps in new treatments that could be coming up or in the new cases. So we recently as well started this initiative to deliberate on potential new treatments for brain cancer patients, because we find that many times our patients and caregivers are desperate to find new cures. They want to know what's new on the horizons. And I told you about the situation where they often would try to read about new and novel treatments and they don't know whether it applies to Singapore. So the medical advisors and Btss have decided to be more proactive about it. So we are compiling right now, a list of what we know is clinically available in Singapore, as well as the efficacy of each kinds of treatment and the adverse side effects. But we are also compiling what we know would be available overseas and the efficacy as well as the adverse side effects. And we hope to put this on our website so that our patients would know that as a Singaporean patient, this is what's available, and you don't have to worry yourself about trying to figure out what are the novel treatments and whether they can access it from Singapore to the overseas markets. And finally, sometimes when our medical advisors are involved in their public events, they would invite Btss to be part of it as well. We are usually given a booth, and occasionally we could be part of the panel, sharing our experiences. And the doctors will be sharing, of course, their talks and giving their educations about the common conditions that brain tumor patients encounter. So in a nutshell, you can therefore see that Btss success was partly built upon the support of active and committed medical professionals. So I would like to urge doctors, if you are listening to this, to consider lending your support to help the patient organization in your country succeed and thrive for the sake of your patients. So with your partnership, you can empower us to live meaningfully and to die courageously. Thank you so much for listening to my talk.
Thank you so much, Melissa. This was extremely helpful, especially I think for the medical community to understand how they can support us and how they can partner with us. So this is extremely helpful. Thank you very much for sharing. I'd now like to actually give a very warm welcome to Aisha and Yasser, who are joining us today. I'll share a brief intro. Aisha Sarwari is co-founder of the Women's Advancement Hub that supports grassroots women and helps tell women's stories across Pakistan. The NGO works to reform all sections of society by passing on the mic to women to tell their own stories. She is also the author of 3 published books, a globally acclaimed public speaker, and is a diversity advocate. She believes the world is a better place with more leadership representation of women of color and people from various socioeconomic and other excluded backgrounds. Aisha is also a caregiver. Yasser Hamdani is a corporate and constitutional lawyer with a keen interest in digital rights, a barrister of Lincoln's Inn holding an LLM and an LLB. He studied economics at Rutgers University in 2002, an Asia Society Fellow, and a Harvard University Law and Human Rights Fellow. He's participated in some notable constitutional and technology cases in Pakistan in the early days of digital rights legislation in Pakistan. As an in-house counsel, Yasser Hamdani served Pakistan's largest telecom company, Jazz, and the government-owned telecom company, Ufone. He is also an author of a widely acclaimed book by Pan Macmillan called Jinnah, A Life. He's a contributing author to The Print, Dawn, Daily Times, Express Tribune, Pakistan Today, The Hindu, India Today, Tony Blair Foundation, and Jinnah Institute. As you can see, Yasser is a superhuman. Today, Yasser and Aisha will speak from the perspective of a brain tumor warrior and a caregiver. I'd like to welcome them.
Thank you so much, Komal. First of all, let me just say that having somebody like you, somebody feisty and amazing and so cause-driven is an honor. And let me also say that Dr. Atharanam's inclusion of us and our story in this is a huge honor for us as well. Yesterday, we were out for a date after months and months of the troubles, the challenges of having a brain tumor in the family. And Yasser was spotting Dr. Atharanam everywhere. So we were having lunch and he's like, that's Dr. Atharanam. And I would look back and I'm like, no, it's not Dr. Atharanam. And he would be like, well, that's him. I need to go say hi to him. And I'm like, no, that's not him. So our entire, we both bow down to the altar of Dr. Atharanam, the science that you all practice and the kindness with which, this very complex and horrible disease, we got a chance to, I think, in my opinion, prolong Yasser's life, not his death. And in 2017, when Yasser first had his grand mal seizure, without adequate care and guidance, we could have not ended up here in 2021. So I want Yasser to talk about his part, and then we will tell you a little about how messed up and dysfunctional we are.
Well, it's very nice to meet you all. I'm sorry I couldn't join you last year. I was not feeling well then because I was out of the surgery and so on and so forth. But the thing is that I would like to say that between 2017, when my first surgery happened in 2017, and then the second surgery in 2020, I managed to do a number of things, and I had enough energy to do a number of things, which I didn't do, which I couldn't have done otherwise. So it was also sort of a wake-up call that, you got to go and get whatever you need to get or you want to get. So for me, that was the real wake-up call, both surgeries. And just to give you an example, I even did the English bar after the second surgery. So I think that was then right afterwards, it was like a month later. And this is because Dr. Ram is a real miracle worker. And, I often tell people that I didn't even have to shave my head in order to get a surgery, which is what happened. The only bald spot or bald patch I have is because of the radiation. Now, just coming to the issues that one faces, there are issues. I find myself less articulate when talking about things, and less I have problems writing, which was something that I used to do very easily before the surgery. So that's happening more with the second surgery. It didn't happen with the first surgery. So that's something that I've faced a challenge with. Otherwise, I find myself in a good place right now. And while there are challenges, I have work challenges, I sleep during the day, but I think those are related to some of the meds and some of the, things like chemotherapy and whatnot. So that, I think, is where I am. And I think Aisha can continue because she's better place to talk about caregiver and more eloquent, as it were.
Also, Yasser is not recently eloquent because he decided to upgrade his books by having braces because he felt that, thankfully now that he has more life, why not have a better jawline? So very invested in his looks as well. As you can see, I am very suspicious about who he's doing it for because I love him anyway, and I've been saving his life with Dr. Amsterdam for a while, but I think he's out to impress somebody. But I wanted to just, perhaps talk about the dysfunction. And I mentioned that we should really be honest about what a brain tumor does to a family. Honestly, since 2017, life has never been like it was. Whatever we knew to be the truth is no longer the truth. Whatever we knew to be our coping strategies never worked. Whatever we felt we had in terms of assets were not really our assets. Whatever we thought were our liabilities just multiplied. It almost felt like quicksand. Everything sort of slipped from our grasp. Financially, psychologically, our relationship has, I think, suffered tremendously. Our marriage has suffered. Our relationship to our children, both individually and as parents, has suffered. Our relationship with our parents, I think, has been problematic as well. I think it's just really, it's like, you're in the orbit, just going around your axis, and then something just torpedoes you off your axis, and you're free flowing into, some place you have no idea where. And you can hope that you don't collide, but you do collide. You keep knocking into things. It's quicksand, particularly for the caregiver, because it's like I experience pain in 5 dimensions. Whenever Yasser isn't all right, and I'll give you an example. About a week ago, I got a call from my daughter because she said Yasser's not waking up. So I, I'm here in my home office, and I took the car keys and I ran, and my other daughter's with me because she's doing her O-level finals. So the two of us kind of cordon off on this side of the house to get some quiet time. And I ran and I went to the basement. I got my car out and I'm driving to Yasser, thinking, okay, this is the day. This is the day he's gone. And I'm trying to kind of do a general calculation on funeral prayer, COVID, SOPs. And when I come out of the parking lot, my daughter is at the road. So imagine me and what's going on in my head, but imagine her being so high alert that the moment she heard that I was leaving and I was running, she just automatically knew there was him. And she then ran her way down the stairs of the apartment onto the main road. We left the door open, jumped into the, I saw her and we just like jumped into the car. It was very 007. We were at the other house, like ASAP, went upstairs. I had the sense to grab a Gatorade on my way there. And so my other, so I have two daughters. My other daughter was like next to Yasser upstairs, and I looked at him and he was awake by then. And I said, "What's going on?" And he said, I just not good. I don't feel right. And, just made him sip some Gatorade. But it was like every time he doesn't die, every time he comes back to me from some ICU or some moment of a close call, it's very strange. It's almost like I start grieving for him even when he's here, because there's so many times I have to prepare myself for the shoe to drop that it becomes very hard for me to deal with him when he's here. And I think it just, grief is a very strange creature. It turns you into a different human being, and we live with it like 24/7. The entire family has that over our heads, and sometimes I'm not well, or sometimes the kids are not well, or sometimes his mom isn't well, but it's like all of us are just waiting to exhale just so that we can get some kind of guarantee that, this man that we, all are devoted to, all the women in his life, 5 of them, that we can just have some guarantee that he will stay, and the depression, I think, is something we need to talk about. The depression and the anxiety. Yasser has obsessive compulsive disorder where it will manifest itself in any form, and the pain is so acute, the manifestations are so crazy. For example, I'll say something to him and he will say, "Do not pronounce it like that, pronounce it like this." And then he will go and repeat the word over and over and over again. So I think last time it was like he was repeating the word slit and split. So he was repeating it over and over and over and over again. And it's kind of like humor helps us, but then I had to put a rubber band around his wrist, and every time he would say it, I would snap it, because we were just out of ideas. Like after 4 hours, he just kept saying it. And so then he was like, okay, I get the whole and I don't know if it works. Like half of the stuff we throw at him as life-saving stuff is probably not that great. But the depression, the anxiety, the fact that you have to show up to work every day for me, that you have to ready yourself for that day, and that you have to just continue to love despite all of it, is a problem. And I think that with anger, with depression and anxiety comes a lot of anger towards the state for cutting so much of my taxes, and anger towards my overall family for the sense of isolation we sometimes feel, and anger towards the healthcare system for not figuring out the exact dosage of the meds so that I'm not always fainting or sick or unwell, or it's hard, and we are very privileged to have the vocabulary and the storytelling and the access that we do. I think Yasser has been writing numerous emails to Dr. Athar, and we've always received a response. And it's not just been a response, it's been a holistic psychotherapy session along with medical care, including movie recommendations. So we are really up there in terms of we are getting globally best in class help, but it's still inadequate.
Well, I think, I totally get what you're talking about and the effect it has had on you. It's terrible what you've had to go through. But thank you for standing by me, and thank you for doing what you've done. There's not once, but you've done it twice. So that is extraordinary. And I think wherever I go, people, the first thing people point out is that you're really lucky to have a wife like that. So Yeah, and as far as sort of the healthcare goes, I think Aga Khan University is, I think that's one of the best in the world. I find it extraordinary that at least we have this institution in Pakistan. I wish this could be extended to all citizens and not just the privileged of the privileged, as it were. So anyway, that's what I have to say. I think we can sort of discuss more later.
Komal, I think you're on mute.
Thank you so much to both of you. I actually can't thank you both enough for your courage and your willingness to share and to let us step into your personal lives for even a moment and to have this window to understand. I can entirely relate your story, and as you were speaking, Aisha, took me back to 2012 when I was a caregiver myself and brought tears to my eyes. But I think for everyone here who was not in either of our or Yasser's shoes will also be able to experience exactly what you're sharing. So I'd like to thank both of you for actually even coming. Yasser, thank you for joining as well. I know this was hard for you as well, but thank you very much to both of you. I'd now like to actually move to the last part of our session, which is the panel discussion. And basically, just share my screen as well. But basically, we will be moving on to actually going through a few of the questions that have been shared with us through this session, and also some of the questions that we put together between Dr. Nitin and myself. Excuse me. The topic for our panel discussion is just whose quality of life is it anyway, and to really focus on thinking of this from the patient's perspective. I'd like to let Dr. Nitin lead this. So Dr. Nitin, please go ahead.
Thank you, Komal. And it's been wonderful hearing these talks. And I've learned a lot from this over my own journey over last 2 years. And every time I listen, there's something new which comes up. So without wasting time, let's start with it, and a very apt title: whose quality of life is it anyway? And many times as clinicians, we are more concerned about the outcomes based on the scans. But to be frank, sometimes it's the other aspect. So we'll start with Aisha and Komal, and maybe Aisha can answer this first. That as a caregiver, what factors do you consider important in assessing the quality of life? Is it the physical factors, the psychological, the financial, or the disease status?
Thank you, Dr. Nitin. I think obviously the right answer is all the above, because all of these are extremely important. You don't pay the utility bills, it's going to drag you down in terms of your level of stress. Overall, I think whose quality of life is it anyway should be centered around the word stress. The patient needs as low a stimulus as possible. The caregiver needs as many structured conditions as possible so that you meet needs to keep the stress levels low, right? So you're functional, but already the patient is, generally non-functional. Yasser, for example, has to nap like a cat. We like laugh about it. He'll walk in, he'll say a few words, and then he'll get tired, and then he'll nap, and he'll come back, eat, and then he'll nap, and then he'll come back and read, and then he'll nap. Because there's so much that they're experiencing inside their head that is not even articulated, because they probably get tired of talking about how hard it is for them. That everything around has to be just perfect, like Goldilocks perfect, for them to just get through life, and life isn't like that. The bills will lapse, and sometimes people will say mean things. Sometimes it will be me, sometimes it will be him, sometimes it will be somebody else. And I think the psychological aspect, perhaps if I was to choose one, is also very important. But I do feel that everything eats into everything else. You can't really choose one thread. But if I had to, I would just say, center caregiving, center medical advice, center home and life and well-being around keeping stress to a minimal and keeping routine and structure as a most important priority.
Right. I think from what I understand is caregivers need to be given more attention, and because the patient, of course, is being attended to, and sometimes the focus of the entire families also remains with the patient, but the immediate partner, like the spouse in your case, has to take care of the patient, the family, and the other parts. So I do understand.
Can I just add to that, Dr. Nitin?
Yeah.
So this past year has been really sort of the year where my mental health has been far worse than Yasser's. I think it's acute PTSD. We could say it's a trauma response. We could say it's fatigue. But either way, like I have been aggressively in a mental breakdown state at least about 5 to 7 times in this year. And it's always like, you're not the one with the tumor. What is wrong with you, right? And I say that it's almost like I gaslight myself. I'm like, I'm not the one with the tumor. What's wrong with me? So I feel really guilty about having this entire, non-functional side to me, which is always in pain, which is always in tears, which is always like breaking down and throwing things and just losing everything, things at the last moment. And I feel like sometimes, there's something called mirror neurons where, I feel like when things are normal or okay, that I need to create chaos to feel normal. Like I just, it's like I've come back from a Vietnam War, and I cannot handle normal life anymore.
I understand. And I think this is where the Brain Tumor Network, wherein they are having volunteers or experts to navigate this entire journey, really is a very good idea. And it need not be physical. I think now technology, pandemic has taught us that even an online availability or over the phone availability would address this. Komal, anything you would like to add on?
Yeah. I'd just add that, everything Aisha says is exactly, I'd reflect that, but I'd like to add that I think in my experience as a caregiver, I was just trying to be practical and go with what next, like as pragmatic as possible, not thinking of the emotional side at all. Actually, almost, I think, blocked it out because I felt that if I keep focusing on that, I won't be able to actually support Taha. And for me, at least, I realized that everything came crashing down after the fact. So when I was able to sort of let go and just what I say thaw, I guess, because I wasn't in this heightened awareness space, which I was for 3 years. And that time it was all difficult, but I think I didn't let it get to me somehow. I don't know how my body worked or my mind worked, but I think it was after the fact that I needed even more support as a caregiver, at least. But I think, of course, for the patient themselves, as Aisha was mentioning, it's trying to keep them away from all of these, issues of are the bills paid, or is the doctor's appointment set? What do I have to do next? Keeping the patient's life just perfect and whatever perfect means in that moment of time. But yeah, I'd just like to add that it's for caregivers, it's a lot of it is after the fact and how to deal with them and focus on themselves because they probably haven't had a chance to do that at all.
I think it's very important from talking to both of you is that somewhere the caregivers also need to be addressed. And I think support groups and peer support groups. And this has been our own experience that the patients, when they meet each other, they exchange numbers, and many times they just keep on talking, the relatives, the caregivers, not the patients. And continuing with this aspect, I would like to ask Dr. Suzanne, because she runs both the caregiver program and also the survivorship program, that how do you find the balance between the quality of life for the patient and for the caregivers? Because when the patients come to you with a new diagnosis, how do you initiate both the programs? Dr. Suzanne?
Well, thank you very much. And I also want to thank just the speakers today for their courage and their honesty. These are things that are really hard to speak about. And I think bringing it out in the open and making it real to everybody is so critical. So just to give you a little bit of a history of our caregiver program, you know, it really started from our caregivers reaching out to us saying, I remember one of my patients' wives telling me, you know, that we just didn't do a good job with the caregiving part. And that struck me really hard because I sort of, you know, try to look at myself as somebody who takes good care of patients. And when she said that to me, I was just like, oh my gosh. And it was just a revelation about, you know, what we were doing with taking care of our patients and missing out on taking care of our caregivers. And so that really jump-started our whole initiative to have this program. And so what we've done is really, again, starting out with the same as the survivorship program, is listening to our caregivers. And you've heard them today about how hard it is and that their needs can vary depending on the trajectory of the illness. The needs vary from the patient's needs. And in addition to what you're hearing about how hard it is and how they have to take on so many roles, right? These are roles that they're not familiar with. But there's also that sense of guilt that we've heard from our caregivers, that they're not good enough, that they can't do enough, that, you know, why are they thinking about themselves? They feel like if they do think about themselves, they're being selfish. I mean, there's so many dynamics that go on. And so we sort of stepped back and said, we wanted to meet the caregivers very early on in the illness. So as soon as a patient gets operated on a new diagnosis, our caregiver team, actually our nurse who works with her, is the co-director of the program, she actually meets with the caregivers in the hospital while the patient is recovering from surgery to help introduce them to what to expect. Because I think you've heard that, you know, the timing between the diagnosis for a symptom, a scan, and the decision to have surgery is usually very, very short. And the disruption to the lives of the patients and the families is huge. And everybody's scared, and they don't know what's going to happen next. And so we really felt that by taking the time to meet with the caregiver at that point in time, to even just understand who are all these doctors you're going to be learning about, what are some of the things that are going to happen when you get discharged. You're going to have to be the doctor, the nurse, the pharmacist, the physical therapist, you know, everybody as you take this patient home. And that's very scary. And so we actually have a lot of resources to orient the caregiver as to what to expect. And we have a number of videos, for example, that they can watch in their own time. We have a manual that we've created, an orientation to caregiving that we present to them as well. And then we follow up with them 2 weeks later in our clinic to make sure that the patient and the family understand the resources that are needed. And then we also, for glioblastoma patients, as everybody has pointed out, that's a very unique population. I think Melissa really highlighted that in her talk about having support groups specific for patients with glioblastoma. So we actually do a check-in with those patients and families. We do a caregiver check-in, you know, before they start treatment, after they start treatment, 6 months later. And we really try to be very holistic in our approach. We have a caregiver support group, so it's purely for the caregivers to meet, because a lot of times when we had our patient support groups, of course, the caregivers are welcome, but a lot of times the caregivers may not want to say things that they think might hurt the patient themselves. And so we felt that it was important for them to have their space to support each other, to come up with strategies that maybe other people hadn't thought of, the caregivers hadn't thought of, and to be really able to have that sort of community, because the isolation I think people feel is huge. Just a couple of key points that I wanted to bring up about caregiving specifically is, our neurocognitive care clinic that we established was really focused on the patient. But as you all know, a patient's cognitive and behavioral changes affects the family. And so we now recognize that to care for that patient, we have to care for that family, for them to understand why the patient is having these issues, how to help to de-stress the situation, to make things more structured. I think you've heard that from Komal and Isha about how to sort of structure those things. And then the last thing I would say in terms of the balancing is the children in the home. So a lot of parents one of who may have a tumor and then they have young children in the home, I think the stress of that is particularly hard. You heard it from Isha as well, right? About how to help understand how they are now as parents, because the roles are very different. But then how do you explain to the children what to expect, why their dad or their mom is changed, what's happening, and helping get resources to understand how to navigate having children. And very, very excited to hear about Anita's work with Oscar's Angels, because I'm also thinking about how do we take that great experience and help the children of patients with brain tumors. Not that the children themselves are sick, but they're experiencing, right, the journey. So I'd love to hear Anita's perspective on that too, just as another side. Thank you very much again.
Yeah. Yes, Anita. Yes, you are muted. You unmute.
Yeah,
yes.
I actually I have a good example, because in Toulouse, for example, our neurosurgery, the reanimation of neurosurgery is mixed. So you have the children and you have the adults. And as we have the experience with the brothers and sisters of the children that we actually care for, and we help them going see the children in the ICU when they are there, the same team takes care of the adults. And so we started a protocol to be able, now it's been going on for at least 10 years, to be able to, with our volunteers' involvement, to prepare the children of the adults they are taken care of in the ICU to go and see them and visit them. And that is extremely important also for when the adults are going to pass away. So there is all this work that has been done, that has years and years of experience, and it's extremely successful, really extremely successful, because the families have the ability to come to us in a different way and have more information, and we have the experience to prepare the children to have that kind of vision they're going to have of their parents or their grandparents.
Wonderful. I think remarkable. And again, I think it's very important for the clinicians who are listening to us, to the neurosurgeons, to the oncologists, neuro-oncologists, that this aspect needs to be addressed. And it's not just taking care of the patient medically, it is the patient and his family. And apart from the medical needs, there are the psychological needs. And in continuation with this, I would like to ask Melissa, because in my own experience, when I try to talk to other centers, to neurosurgeons, to oncologists, many times, and to the hospitals, many times there is a resistance because they don't see an immediate benefit. There is not much of financial benefit. There is not much immediate scales to tell that this is beneficial. So how do you motivate? Because in your talk, you said you have a lot of doctors who help you in various aspects. So what is your message to doctors and to those support groups who want to involve more centers to motivate them or to help such support groups?
Okay. I would like to say that, many doctors, they really have the heart for the patients. I mean, just like yourself, Nitin, you started something in India for your patients, and also Dr. Inam, you are also involved, isn't it? Right? So I think we have to understand the doctor's perspective of their involvement, because firstly, doctors are very busy people. they have to attend to emergencies, and they have a lot of things to do. So I think when you present the opportunities to the doctors to be involved, you have to appeal to their heart, but you also have to show sensitivity to what they are concerned about. Like, for example, they'll be concerned about the workload, right? So you have to, like what BTSS does is to not get doctors involved in the running of BTSS. This is a patient function. So we decide the programs, etc., etc. And we are very clear about the doctor's involvement. Like, for example, it's the area of vetting and reviewing resources. Well, they can do that, isn't it? And when you have a panel of doctors, you can, and they're multidisciplinary, you can also divide the work for them. Okay, and you leave it to them to decide how they want to do it. Perhaps they may involve their peers as well, and I really welcome that. And I think also the other thing that the patient organization needs to do is to build your credibility. The doctors have a heart and they like to be involved, but they want to make sure that they are involved with patients, patient leaders who have the commitment and the credibility. So you have to build trust. Like, for example, when I have talks and the doctors are featured, I often remind the patients and caregivers who are attending that this is not a personal consultation session. Now, doctors are really afraid to be like stuck there, isn't it? I say, everyone, please be reminded that this is not a personal consultation session. The doctors are here to share their expertise, right? So if you want further questions to be answered about your condition, you have to make an appointment, something like that. So, I make sure that I know about all these. And how do I know about all these? It's because I talk to the medical advisors. In fact, I have like Dr. David Low, he's the vice president of BTSS. So he talks to me very openly about their constraints, and I share with him very openly also about our expectations. And somehow through our communication, we are able to know how to navigate each other's world, that we can come to some sort of meaningful collaboration. And I think the thing that doctors want to hear is when the patients go back to them, the patients say, BTSS has been a great help to me. Thank you for referring me to BTSS. So patients' organizations have to build credibility to show that we can value add. And when the doctors can see that, they will give you their support.
Right. Wonderful. That's a very good perspective, Melissa. And continuing with, again, this aspect, I would bring this question to Anita. It's a remarkable. I was very much impressed. And we see our pediatric patients being wheeled in, and from the OT gate, they just start crying. And I can see the gut-wrenching emotions on the mothers and the fathers. How do you motivate your volunteers? It's a tough job. To get sustained volunteer backup. I tell you, I have been trying to get volunteers. I am requesting caregivers who have successfully treated, their patients are treated, benign tumors, they're back to their life. A lot of medical students, but it's so difficult. So how do you do that? And because a good volunteer is very support is very important for such patient support groups.
Yeah, it is, and I think there is not one answer, to tell you the truth. It is difficult, full stop. I think it is difficult in every country. We never have enough volunteers. That's just reality. I think you just motivate them. You can motivate them in making them feel special, because they are special, and I think, in our cases, they feel it's particular position for us, because our volunteers are real member of the teams. And when they realize that the teams do respect them, and that is the key thing, they are not thought of as outsiders, like unfortunately most volunteers are, but as for the preparation and their expertise, they are really considered 100% members of the team, and they feel like it. And that really makes them very strongly attached to the team and wanted to stay with the charity. So I think you have to teach also the teams to trust volunteers. At the same time, you have to have on the other side a charity, an association that is very serious on training. I cannot stress that enough. You have to have volunteers when they have the kind of positions we have, of course, that are very highly trained. Very highly trained. Then everybody's happy because they are trusted and they feel really a part of the group.
I think that's a very valid point wherein you involve them with the medical team. I think they become responsible and they feel that they are part of something very important. A very valid point. Now I would like to ask Christy, and Christy, I'm really impressed by the navigation because I can understand that a patient has to go. It's a simple scenario in the hospital from A to B to C place, and it's a struggle for them, and especially in large hospitals. Now, what I want to know is, in your own experience of your organization, what are the most vulnerable points during the entire course for a patient and for a caregiver, and how do you try to address them? Do you preemptively address them, or do you address them as and when it comes?
That's a great question. I think it's a mixture of both. You know, I think we try to preemptively address them, and we do address them as they come up. But, you know, there's not one particular point. I think there's many points along the journey when they're newly diagnosed, when they have a recurrence, when their treatment stops, or maybe they're in between treatments because they feel like they oftentimes don't have control anymore of what's happening. And, you know, there's nothing going on. So a lot of times that creates some anxiety. I think, you know, when scanxiety, everyone's heard that term. I think, you know, when someone's going for their scans, it brings up a lot. Also, when there's tension in the family about different treatment options or long-term care planning. So we really, like I said, we try to do, you know, all of it. Also, when there's a loss of, when patients are very symptomatic and maybe are having trouble communicating, I think that can be difficult for the caregivers, as we've heard before, as well as the patients. So there's many times along the journey that I think it can be distressing for patients and caregivers. And we just, and you never know, every patient, every family is different. So you don't know what's going to be the most distressing to that unit until it happens, I would say. So we're just open and here to support it as much as we can, when we can, and try to meet the patient where they're at.
Right. And just to follow up with it, how many patients or families does your navigator take care of? Is it one at a time or is it many at a time?
We have many at a time. So last year we navigated over 550 families, and every navigator has about, I would say, an active caseload of 50 families that they're navigating at any one time.
Okay, so that's a very significant number because they would be getting random phone calls and very challenging and great. But I think that's a very good idea, and we all can sort of think of having these navigators in our hospitals to begin with. It could be a neuro nurse, it could be a physician assistant, and it really, as you have shown, it really makes things very easy. Yasser, you would like to add anything about these concept of navigation and the vulnerable points, or maybe Anita, you can, Aisha, you can.
Yeah, I think Yasser can take it. He's just had a small nap, so he's good to go.
Okay.
So I think there's obviously a lot of room. So for example, let me give you my example. When I came out of the surgery and, I was going into radiotherapy, the adjuvant treatment, my expectations were not entirely met by the adjuvant, therapy, or let me say that I felt that I was out of my depth. So that I think was an issue. As far as the navigation is concerned, I think we need to navigate the issues in terms of getting brain tumor patients enough therapy and the kind of help and aid that they need in terms of going through difficult patch. Now, I went through a very difficult patch. I had extreme depression for a very long time, for 4 months or so. And I became slightly suicidal, or I should say, suicidal period. And that was a very hard time for me when I came out of it. There were extraneous factors as well. I don't deny that, but some of it was when I took the radiotherapy, the radiation, that took me back basically. So overall, those are the kind of issues that I imagine would be, would need to be dealt with for better care in the future.
Then, Dr. Nathan, can I just add?
Yeah.
Yeah. So there were two particular times where I thought that the holistic approach was completely missing. One was right before the brain tumor surgery, where Yasser was underwent catheterization, which is a normal standard operating procedure before any surgery. Catheterization by any measure for a man is a very painful experience. Now, you have geared up all your willpower for the surgery, right? And for getting under the knife, having your head open while you're awake. But nobody tells you that there is a bump right before it. And so what happens is that when staff just comes in, takes your sense of control away, cuts down, catheterizes you, you're done for it. That's all the willpower you've had for that day. And that sense of loss, that sense of not being in charge, that sense of not just somebody had to just say that right before you go into surgery, it'll be a tiny little pain, so that things like that, things like just letting expectations management happen. And the other time, I think, where we were completely both out of our depth was, I think, 2 years into the treatment, I think after the first surgery, when Yasser had, actually after the second surgery, which was during COVID, by the way, and had its own challenges, we had to go through radiotherapy, right? So again, this is like a patient who's had his sense of control taken away over and over again. And radiotherapy was so difficult. And for some reason, we thought that because you had undergone the second surgery, nothing can be harder than that. But we didn't expect that there's something that can knock you off your feet in such an extreme way that he would want to try and kill himself. I mean, I didn't have anything in my toolbox for that. What do you do? Because I just kept thinking he wants to live.
Right. So I think, we can really understand the challenges, and to be frank, it's so difficult for clinicians to look at these aspects because they're not exposed to. And I think we as patient support groups or peer groups really are exposed to such things, and it is very, and I'm grateful for you to highlight these things in front of our clinicians, so that each one of us is sensitized to at least start in small baby steps and think really about having small support groups. Maybe one nurse of yours can be taken as volunteer and just given time and space to talk to the family who is getting admitted. I think time is always a concern, and I'll put my one last important question to Kathy. And Kathy has really been a role model for all of us. She's always so enthusiastic. Kathy, this is fine. We are trying, all of us, in small bits to work out. But when it comes on a bigger scale, say a national level or a state level or a county level, how do you approach the policymakers at each of these levels? Because again, for them, it is setting up a radiation machine, getting a microscope in the department, getting buildings is fair enough. They understand that. But when we talk about other aspects like empowering the patient, sometimes they look at us, what are you talking? What more do you want? So how do you address them in a very positive way? And how do you try to sort of get things done for the benefit of patients on these aspects?
Okay, well, thank you, Nitin. Before I answer your question, may I just add one more comment, quick comment, because I know we're short of time, to the caregiver issue that Komal and Aisha were talking about. I mean, as a former caregiver myself to my son, when he was diagnosed, it was like being pushed off a cliff without a parachute. And nobody told me about the existence of support groups and patient advocacy organizations. When I ultimately did find these groups, they really were lifesavers to our family. But there's another, and you develop a kind of routine as you go through the months, the years, however much time you have. In our case, it was 7 years. You develop a routine, you know, the clinical visits, the MRIs, the waiting, the scanxiety, all of that develops into a new normal, a way of life. But there's a second time when, as a caregiver, you are pushed off another cliff. And that is after the fact, as Kamal was describing it. Because when the patient is no longer in your care, you are forgotten about as a caregiver. And I really do think that support groups and healthcare professionals should continue, if they possibly can, to be in touch with caregivers, to make sure they are on the road to recovery, to make sure they are able to function again and, you know, resume some kind of life. So I see it as a continual process that doesn't end at a particular stop. It's when the person feels that they can go out into the world, the caregiver feels they can go out in the world again. So I just wanted to make that observation. And turning now to politics and policies and governments, I did say in my presentation that a lot of this boils down to politics and money. We need money to pay for services, you know, to pay healthcare professionals, and we need policies that support healthcare professionals and the delivery of the best possible healthcare services to patients with brain tumors. And there are ways of getting the politicians on side. Sometimes you might find a politician who actually has a personal experience of a brain tumor in their family, and they will be very sympathetic and support what you're trying to do. Other times you have to make the first move and be proactive and get these politicians on side. And one way of doing that is to, in the UK, for example, we've established an all-party parliamentary group on brain tumors. And that is a cross-party group. It's not party specific, a cross-party group of MPs, members of parliament, who get together several times a year and are presented with the latest challenges we in the brain tumor community face. Here in the UK, research funding for brain tumors is about 1% of the national spend on cancer research, which is very low. This is a similar case in other countries. So we have tried to explain to politicians how they must change that from the government perspective of providing more funding for more research into brain tumors, because brain tumors have the highest level of life years lost than any other cancer, pretty much. And, you know, we need the amount of spending is not equivalent to the amount of suffering and, you know, difficulties that patients face in the brain tumor world. So here, as I say, we have a UK parliamentary all-party political group. In the US, and Suzanne will know much more about this than I do, but I can just tell you that they have an annual event called Head for the Hill, which again brings the patients into, and the caregivers and healthcare professionals into Washington, D.C. to meet the senators personally, face to face, and tell them what the problems are. Communicating by email and letter is all very well, but it's when you talk to these people face to face that you can really make an impact. And that's, of course, been affected by COVID now. But the Head to the Hill, I think there are hundreds of people that are involved. Am I right, Suzanne, in the activity? It's a really successful one. And just generally in Europe, well, anywhere, if you can find other organizations outside of your own charity or foundation who are actively participating in policy work, latch onto them, piggyback onto them, and go with them in their campaigns. We do this with an organization called the European Cancer Organization, which is a policy organization working at European Commission level with people representing cancers there. And there are also the European reference networks I mentioned in my talk, where that's also, there's a lot of policy involved with that. You have to cultivate this. It's hard work, but it can be done, and that's been demonstrated in other countries. And of course, the patient stories are so important when you do go to see your politicians, because that is what they really want to hear about, the patients, and they want to hear from them as well. And I think that's, I can finally say, if any politician is in doubt about the benefit of what everyone on this group is doing, all they need to do is watch the video of today's presentations. That's the short answer. Show them this video and the benefits that can be had through patient engagement and patient advocacy.
Wonderful. Thank you, Kathy. As you always put it so nicely, and it all reflects the amount of effort you have put and to bring us all together. And with this, I would like to conclude this panel discussion. There are still a lot of questions, but I think it's a never-ending thing, and we can be in touch with each other over WhatsApp, emails. I would once again like to thank all the speakers for their own wonderful insights and sharing their own experiences. And I would like to thank Dr. Inam for organizing this once again. And also Komal for putting so much effort. And finally, Aisha, I would really like to thank you. It's tough as a caregiver. We all we see it daily, but I think you have the mindset to navigate it. And now with being around, maybe there is always further option available for you. So with this, I would like to just make one or two remarks, concluding remarks. And these remarks are more for our audience, our listeners, our clinicians, that as you have gone through these various presentations and also the discussions, the brain tumor support groups should be considered as an important part towards providing a holistic care. And this is an important part, and we should all seriously start thinking about how to incorporate these practices into our practice. And it really helps to navigate the cancer landscape, as we have heard from all of us. And the aim should be to deliver a good, timely care, but also to provide the psychological support, which is such an important part. And I would also like to say that this is a new concept in our Asian communities, in our Asian societies, especially because we have the habit of having joint families, larger families. And if you say, sometimes it is just shrugged off, oh, what do you want? What is support group? We are providing you with all the care. So I think it's time to introspect all of us. There are going to be challenges. There are going to be social challenges, and we come across daily. Many times the caregivers just say, no, we don't want your support. We are good off. But then there is always, for one who says no, there are two who are willing to say yes. So try to incorporate these. And I also feel that this support should be real time, as Christy has mentioned. Navigating the landscape, it should not be an afterthought. We should not send to a support group once the treatment is over. No, it should be right from the time the patient is diagnosed, right from the time the patient comes to your OPD with a scan which shows a tumor. That is the time we need to get them involved. And start with small beginnings. This is what has been shown to us. Take a neuro nurse, take a social worker who is interested, and you'll find one person and give them one small room, and just send the relatives, the patients to their room. And I think that's it. The rest thing will just fall in place. So with this, I would like to end this session, wonderful patient-centric session. And Komal, handing over to you.
Great. Thank you so much, Dr. Nitin, for sharing and for summarizing everything so well. Thank you to each and every one of you who participated. and came and spoke and shared your stories, your personal stories, and your motivation to join. For actually being so accommodating and responsive when we reached out to you as well. I think I find myself to be lucky, and I'd like to thank Kathy for actually introducing me to a lot of the speakers who spoke today. I find myself to be honored and lucky that you all participated, and actually a North Star for the Brain Tumor Foundation of Pakistan to eventually try to as a vision to try to inculcate a lot of the activities you're doing. So thank you to everyone, and I'd like to wish you a good evening, a good day, good long weekend to everyone in North America as well. Take care.
We were going to have a group photo, Komal.
Yes, we'll do that as soon as I think we go
Okay.
offline.
Okay.
Live streaming should be off now. We can turn the live
Thank
stream
you.
off, Sharif. Sharif, you can turn off the live stream, please.